Guys, this time we're going to do some cultural competence. It includes the diversity, equity, inclusion part of our education process. It's really important that we provide equitable. Again, equitable and equal are very different. Equitable is you have two children, one needs Band-Aid, one needs an ice pack. You give the one that needs an ice pack an ice pack. You give the one that needs Band-Aid a Band-Aid. Equal is you give them both a Band-Aid. So we want to make sure everybody's getting the care they need. So foundation is just based on understanding Standard 9 of the ANA Code of Ethics, which is ensuring respectful ethical practice and reducing health disparities. Leninger has a transcultural nursing theory that establishes this as a formal field of study. So defining culture is the integration of behaviors, including communication, language, action, beliefs, values, customs, and institutions. It's a big impact on how people perceive and receive healthcare, and it influences their views on health and illness. And so it's important that we understand different cultures and don't make assumptions about what somebody's going to think. So, recognizing our own biases. Explicit biases are those conscious thoughts and beliefs that you know. Um, This can be something as simple as thinking that somebody who assaults a child does not deserve care. That is an explicit bias. And that explicit biases aren't always negative like that either. It can be the pervasive thought that certain cultures are just smarter than other cultures. That is a positive bias, but it is still a bias. Implicit biases are involuntary things that we do, things that we just unconsciously think that impact our care delivery. So we want to look at cultural diversity and we want to embrace it and include everybody and give them good care. Um, the more we are inclusive and understanding of cultural diversity, the better people are going to do with their health. So we need to be inclusive and understanding that other cultures are relevant. It's okay to not understand a culture, but it's not okay to think that it's not as good as your own. Health disparities are just those health outcomes that are greater or lesser among different populations, as compared to the majority of group. In the United States, there are some major health disparities when it comes to rich versus poor, or black versus white, or um, city versus rural. There's just a lot of different groups that have better outcomes than others. 80% of African American females will be overweight or obese compared to 64% of non-Hispanic white females. That doesn't mean that there's anything wrong with either group. It's just that's a disparity. Um, there's a lot of uninsured population in Hispanic population. Asian Americans are more likely to develop chronic hepatitis B. It's not really known why, it's just a fact. So it's important that we understand these disparities so that we can work with these populations and help increase their access to care or make better health outcomes for them. Factors that can impact access to care: transportation. Rural populations, it's very difficult to get transportation to healthcare facilities. In more urban areas, it's a little bit easier because there's more public transportation available. Health insurance, socioeconomic status. As we all know, you may have health insurance, but you may have a $17,000 deductible that doesn't pay for anything until you hit that $17,000 deductible. So people are avoiding going to the doctor and having worse outcomes. Religion. As I've mentioned before, Jehovah's Witnesses, they're not likely to accept blood products or any organ that is full of blood, like the liver or the heart. Um, Another religion that may be wary of accepting care are the Christian Scientists. They believe that believing in God and praying will cure everything, and they don't believe in modern medicine all the time. Geographic location, like I said, rural versus urban. Urban's going to have a little bit more access to care simply because of the proximity, versus rural areas tend to have less population density. Cultural influences: sensory deficits, physical deficits, mental and cognitive disabilities, race, ethnicity, gender, sexual orientation, all of these things Limited education and language barriers. All these things can limit access to care and really make people struggle with maintaining their health. So it's important we understand that all these things exist and we look at them when we're looking at patients instead of just labeling them as non-compliant. Perhaps the 47-year-old Hispanic man with uncontrolled diabetes doesn't have health insurance, lives in a rural area, so doesn't really have good access to transportation or healthcare facilities. And if Spanish is his first language and you're only speaking to him in English, he might not understand what you're saying and might not understand the importance of this medication that you prescribed him or how to take it. So it's important we recognize all these different factors and address them in order to improve health. Health equity wants everybody to have their personal highest. It's like I tell my daughter with her test scores. I don't expect anyone to be the best. I expect everyone to be their best. And that's what we're looking for with health equity. We don't want health equality. That is virtually impossible and it's just going to frustrate. We want health equity. We want everybody to have those inequities addressed and be able to be at their personal healthiest. Um, and it empowers people to understand and use health information if we're working with them with their health literacy. So we want to know where they are and we want to meet them there. Vulnerable populations. Those are the groups that are at high risk for poor health outcomes. It's social, economic, environmental. People who are ill are at bigger risk for having a poor health outcome. People with disabilities, older adults, immigrants, marginalized ethnic groups, people with chronic illness. When it comes to mental illness, those who are on the LGBTQIA plus spectrum are at much higher risk of significant mental health crisis, not because of anything internal, but because they're so marginalized. So Madeline Leninger is one of the first people that really looked into transcultural care and developing a culture care theory of nursing. In 1950, she developed these theories and addressed cultural care knowledge gaps among nurses. In the 1980s, she officially established this nursing as a formal field of study. And in 2018, she updated to include biologic factors for comprehensive assessment. Ongoing, it's going to assist nurses in planning and providing culturally appropriate care, which will improve outcomes and reduce disparities. If we understand patients and their own personal cultures, we will understand how to get them healthy. So the Sunrise Enabler established 5 core categories. The upper level, which is worldview, cultural, and social structure dimensions. The rays of the sun are your basic elements of the assessment. Central core is interactions among those basic elements. And then this focuses on individuals, families, groups, communities, or institutions in the health context. And then 3 modes of care decisions and actions. So the modes of culturally congruent care, these are guiding principles for nurses to help you make those good decisions with your patients. We want to support them to maintain their personal beliefs and values related to their culture. We don't want to change what they believe. We want to incorporate what they believe into how we're caring for them. So we're going to help them adapt their beliefs for safety and wellness, or we're going to help us adapt their care to their beliefs. And then we're going to support them restructuring their beliefs to improve health outcomes. If they believe that all illness is because someone put the evil eye on them, we're going to help them restructure that and determine how to be their healthiest. Effective communication. We're going to use those medical interpreters. When there's a language barrier, we need medical interpreters to have clear, accurate communication. Family members increases translation errors, confidentiality breaches. You can't tell someone they have HIV through their family member because you have to have a ton of paperwork just to report the HIV to anybody else that has to be signed by the patient. So we need professional interpreters who are part of the patient's care. with a lot of patients who want their family members, sometimes their family members are really hesitant to tell them what we're actually saying. I had a patient who wanted her granddaughter to translate, and her granddaughter was afraid to ask her the questions that were required to give good care. This patient had a vaginal odor. I needed to know if she was sexually active so we knew what we were working with. And unfortunately, her 13-year-old granddaughter she wanted to translate was not comfortable asking those questions, so kept reassuring her grandmother that everything was okay. Medical interpreters are really, really important. So, our key takeaways are that we need to be culturally competent. We need to understand that there's a lot of different cultures, and we need to be able to put aside our own biases and take care of the patients. And that health equity is foundational to improving health